Hello and welcome back to MLab 1101, Introduction to Clinical Laboratory Science. My name is Dustin Scott Brewster, and this is going to be the first of our six-part presentation series on clinical laboratory testing. Our first presentation is going to cover the urinalysis department. So before we jump into the study of urinalysis, let's first have a very brief discussion on the anatomy of the urinary system. Urine is considered an ultrafiltrate of the blood. Blood first enters the system by way of the renal artery through the afferent arteriole. The blood is then circulated through many nephrons, which act to filtrate out waste products and return non-waste products back into circulation through the efferent arteriole. So down the aorta through the renal artery through the afferent arteriole, we'll go over here on this side in this cross section, the blood goes through the afferent arteriole into many nephrons. The blood is filtered, it comes back out through the efferent arteriole and back into circulation, that which isn't waste. So after the blood is filtered, urine comes down here through the kidney. This is the ureter, one of two ureters for each kidney, into the bladder and out the urethra where it's discharged. So what is the function of the urinary system? Well, it helps to maintain pH. It participates in metabolism. It's used to regulate water balance and therefore blood pressure. And it's also used for excreting waste products that we know as urine. So what type of analysis do we do on urine? There's a physical analysis of urine when it arrives in the clinical lab. We do a chemical composition of the urine, as well as a microscopic analysis of urine. The reason for doing so is to help detect things like disease, possible infection, metabolic disorders can be detected through urinalysis, as well as substances such as drugs of abuse. What types of urine specimens would you expect to find in the clinical lab? Well, the most ideal specimen is a first morning specimen, which is often the most concentrated. Less ideal, but often well received, is a random urine. Different types of collection methods include a midstream, which is collected midway through urination and is a preferred collection method. There's also a clean catch, which requires the patient to use a cleaning wipe to clean the urethral opening before urination. In addition to these options, there are catheterized specimens that are often received in the lab, and of course those are going to be the most sterile. Urine is best if examined within 1 hour. If that's not an option, you can also refrigerate it at 4 to 6 degrees Celsius and the urine will be stable for up to 8 hours. If you fail to examine the urine under these conditions within an hour of receiving it in the clinical lab or up to 8 hours refrigerated, things could happen such as increased bacterial growth from setting the specimen at room temperature. That bacteria will grow and utilize what glucose is in the urine, so you'll have a falsely decreased glucose level. Those bacteria will also increase the pH in the urine. It'll decrease the ketones present and decomposition of casts if present upon collection. So the first step in analysis is the physical examination of the urine. What we want to do here is note the color of the urine, and here's an idea of the types of urine colors that you may receive in the clinical lab. Light yellow, yellow, amber, red, and brown. Light yellow, pale yellow, or straw, which is often called, is indicative of a more dilute specimen, maybe somebody that's drinking more water or has diabetes insipidus and is urinating quite a bit. Yellow urine is the most commonly found urine and is the normal color of urine. Amber could indicate the presence of bilirubin, which could be the result of liver damage, which you see here in the middle. Red could be due to the presence of blood in the urine, and brown on the far right may be the result of a melanoma. Also, for physical examination of the urine is the clarity. Different clarity options could include clear, slightly cloudy, hazy, or turbid. Clear is what is normally seen in normal fresh urine. Slightly cloudy or hazy urine can indicate the presence of a more concentrated specimen, possibly mucus, sperm, or prostate fluid, as well as skin cells, the presence of crystals, or other contaminants in the urine. Cloudy urine in fresh urine could indicate a bacterial infection. Again, if the urine isn't evaluated in a timely manner, it will be old and could indicate the presence of bacterial growth from delayed processing and not a true infection. Turbid urine could indicate the presence of a urinary tract infection or a sexually transmitted infection, as well as protein or kidney failure. The next type of analysis we do on urine is the chemical examination of urine. The chemical examination of urine tests for the pH, the presence of protein, glucose, ketones, bilirubin, the presence of blood, urobilinogen, the specific gravity of the urine, the presence of leukocytes, and the presence of bacteria. So again, it's ideal to test the chemical examination of the urine within 1 hour of collection, and it's also an option to test if refrigerated and tested within 8 hours at 4 to 6 degrees Celsius. To test for the chemical examination of urine, you want to aliquot a sample of urine, dip the reagent strip, which you see this woman holding here, in the urine specimen. Make sure the pads on the reagent strip are completely submerged in the urine. Blot off any excess urine, and then compare the color change on the chart, which you see on the tube here, the reagent testing tube here. Each of these reactions takes a specific amount of time, and you can compare the reactions on the key that you find on the reagent tube here. For each of these reagents, pH measures the acidity or alkalinity of the urine. Protein detects the presence of protein in the urine. If present, this is known as proteinuria, and it's often seen in renal disease and urinary tract infections. Glucose measures glucose in the urine and could indicate the presence of glucose exceeding the renal threshold and is seen often in diabetics. Ketones are excreted as a byproduct of fatty acid metabolism, and this is known as ketonuria, often seen in diabetics. Bilirubin is a byproduct of hemoglobin breakdown and is seen in liver disease and bile duct obstruction. Blood detects the presence of blood in the urine. The blood reagent strip detects the presence of blood in the urine. This is known as hematuria and can indicate infection, trauma to the urinary system, or bleeding of the kidneys. The urobilinogen reagent strip tests for the presence of urobilinogen, which is a product of bilirubin degradation, and it is often elevated in the presence of hepatic or hemolytic disease. The nitrite reagent strip tests for the presence of nitrites, which are produced by gram-negative bacteria converting nitrates to nitrite. The presence of nitrites can indicate an infection. If present in a fresh specimen, if present in an old specimen, this could result in contamination. The leukocyte esterase is produced by white blood cells in the urine. If white blood cells are present in the urine, this is known as pyuria and can indicate a urinary tract infection. For the microscopic examination of urine, we won't get into, but it's performed after the chemical examination of urine, and it checks for the presence of cells, red blood cells, white blood cells, epithelial cells, or possible spermatozoa, microorganisms such as yeast, bacteria, parasites, crystals, and casts. That's going to conclude the first of our 6-part presentation series on clinical laboratory testing. We will pick this back up with part 2.